find out about outbreaks? How have you learned that a possible outbreak was happening?
Through statistics or monthly reports that come in from health facilities.
Fantastic. Yeah, so statistics or monthly reports is a great way to find out about outbreaks. And what else were you going to say?
From people talking, telling us about what's happening out there, or if there's any problem that we need to know. Our friends telling us on the road or somewhere that, look, this is happening like this, like that. So like sometimes we get it from our people out on the streets.
Terrific. Okay, that's really great. So we can find out about outbreaks through statistics, through collection of monthly reports and analysis of data. But you also mentioned some other ways you may find out through the community, through your friends, through perhaps clinicians who notice something different. Occasionally through people who work in the laboratory, from religious organizations or religious leaders, traditional media, social media are some other ways you may find out. So we actually, both of those ways are actually surveillance. And the first is that one that you talked about, regular analysis of the monthly reports. And so that's really sort of traditional surveillance or indicator-based surveillance. But we also hear a lot of outbreaks, actually probably more than 50% of the outbreaks that you will find out about through what we can call event-based surveillance. So through your friends, through the community, through healthcare workers, through the media. And so the way that we find out about these potential incidents that we need to respond to is through surveillance. So let's talk about what surveillance actually is. Are there any problems with the presentation? Can you see?
All okay there, Gibson?
It's just a multimedia, but we can hear you clearly.
Oh, okay.
We can hear you clearly.
Can hear now?
Great.
And you can see?
Yes. Blackout, but it's appearing on our laptop. We can still see it and hear you clearly.
Wonderful. Great. So I'm glad that you can see and hear clearly. So I thought we would talk about what surveillance is and how you're going to use it as a rapid response team. So this is the standard definition of surveillance on the screen right now. So surveillance is the systematic, ongoing collection, collation, analysis of data, and the timely dissemination of information to those who need to know so that action can be taken. Now, I'm not going to go into this in detail today, but if you want to know more about surveillance, your epidemiologists in your area are a great person to ask, and they can give you a little bit more training. But in a nutshell, surveillance is data for action. And when we think about those two types of surveillance that we talked about before, we have the indicator-based surveillance, which we thought of as more the traditional surveillance. So where we have standard reporting forms, there are case definitions in place, and we know who to report to. There's a schedule, and it's usually on a specific disease or a syndrome that you're collecting these data. And an example is the National Health Information System. Event-based surveillance is a little bit different. So this is more of an early warning system where we capture information about an event which may pose a threat to public health. This information is generally not very structured. There's no schedule. It's not for a specific disease. Generally you'll receive a report just as you're leaving work to go home or on the weekend. So it's a great way to identify outbreaks and new diseases that we haven't seen before. The reason I'm talking about these two different types of surveillance is that the way we need to triage and verify these reports is a little bit different depending on where you get your data from. So let's talk about that a little bit more. So you find something that is unusual. It may come from a surveillance report. As you mentioned earlier, it may come from a friend, it may come from a coworker, but you hear about something unusual. And so what do we do next? Now, you don't have time to follow up on every possible outbreak that you hear about, particularly for this event-based surveillance, where you're going to get a lot of, your friend may tell you something and then you start to sort of investigate it a little bit further. It could be a false report. It may not be really an outbreak at all. So how do you decide which events you need to follow up on and need to action? Well, you can use a 3-step process. The first step is triage, the second step is verification, and the third step is risk assessment. Now, this is a little bit of a complicated diagram, so we're going to look at this a little bit more closely. And that first step, the triage step, is where you've detected something unusual. So, you may receive a notification that there's been a report in the media of somebody dying. And when you look at it a little bit more closely, it's not from any time recently. It's from, 3 years ago or 10 years ago, perhaps, that they're talking about something. So the first step of this process is called triage, and it's where you screen out, the data that you're receiving from the report forms, from your analysis, and it's where you screen your information that you've received from your friend, from your coworker, from the media. And you try and screen out any obvious errors, any duplicates, any kind of mild illness. Everything that is left is called a signal, and it could potentially pose a risk to human health. So once you identify a signal, you need to verify it. And this step is really important because you're not going to have the time to verify everything. So you need to really look through the data and the information carefully and pick the reports that you think could potentially be an outbreak. So with surveillance data, the triage consists of 2 steps, and that is analyzing the data. So looking at the quality of the data and describing the epidemiology and interpreting what you see. So you need to make sure that if that increase in cases that has been reported is genuine and it's not due to something else. So some questions to ask are, potentially there are more tests being sent to the laboratory. So there may be more laboratory confirmed cases. For some diseases, particularly those that are mosquito-borne like dengue, there will be changes at different times of year. So even though you're seeing an increase in cases, is it similar to what you saw last year and the year before? Now, that doesn't mean that the cases are not a concern and that you don't need to do some kind of public health action, but it may not require deployment of the rapid response team. So with the surveillance data, we need to consider if it is a true increase in the cases. with those reports that you receive from the media, from your friend, the information will not be as complete as the other types of traditional surveillance. So you're likely to find lots of errors, lots of information that just you really don't need to follow up on. So you need to filter this information into those which you do not need to follow up on because they're mild illness that is being reported in the media, it is not severe, or because of duplicates or some kind of other error. And you filter the information and you find the ones that you genuinely think could be something that a rapid response team needs to respond to. So some questions that you may want to ask are on the screen right now. How reliable is the source that you're getting the information from? Is it just a rumor that you're hearing in the community, something that's come through on WhatsApp that's been forwarded to you? Or is it somebody that you know that works at a healthcare facility and that has some medical training that is a little bit more reliable? Think about whether it's been reported just by one person or from a few different people. Think about if something similar has been reported in the past and was something of concern. So have a little bit of a think about this information and see if you need to gather further information or if you can just discard it and not need to follow up on it. So you found something unusual, you've triaged it, and now you have something called a signal. It is a potential outbreak or event, public health event that you need to verify. So if we go back through the process, this verification process, again, we're screening out false alarms, errors from things that are truly outbreaks or public health events. There are many different ways that you can confirm that your signal is a real public health event. With this verification step, you need to actively follow up. You need to contact the local health authority, contact the original source, cross-check against some surveillance data that you have, potentially, if this is a piece of information that came from your friend. Maybe you can look at the surveillance data to see if you think it is a real outbreak or not. And this is really where the epidemiologists can provide you with a lot of support. You need to verify that your signal is real. And once you do that, we can call it an event. Now, sometimes you may not be able to confirm something is real just by making phone calls and looking at some information. So very occasionally, when you think it is very serious, you may need to deploy as an RRT before you're able to verify that a real outbreak is happening. But we hope most of the time you'll be able to confirm just from phone calls and from looking at information. So you have a signal, you verified it, it is a real outbreak or a real public health event that is happening. It is a verified disease occurrence or something that creates the potential for the disease as well. It could be infectious, it could be food safety, it could be chemical, radiological, it could be transmitted by people or animals or food. And so you have something, you could also be a disease of unknown origin. So what's after that? Well, this last step we're actually going to talk about a little bit later, not in this presentation, but it's the last step is a risk assessment where you undertake a systematic process to assign a level of risk to an event to help you make a decision about whether or not a response is needed. And as Barry said earlier, the response can be from your office, it can be providing advice over the phone, it can be providing resources, or it can be physically going out to the community or to the location to help investigate the outbreak and put control measures in place. Here are some general rules for when an RRT should respond. But again, we'll talk about this process in the coming presentation. So where there is a true increase in illness in the community, there are large numbers of unexplained cases of a disease. It could be rapidly increasing case counts, where there is severe illness or death. It could be where you don't know what's causing the outbreak. So when you detect something unusual from your surveillance reports or from your friend or from somebody in the local healthcare center, you decide which events will require action by following a 3-step process. The first one is to triage, the second one is to verify, and the third one is to conduct a risk assessment. Does anybody have any questions? If not, we're going to move to the scenario. And we're going to have a group discussion about what we've just talked about and apply this to a scenario. So I'd like everybody to divide up into groups of 3 people for this activity. So if everybody could work with 2 other people, and if you can just spend 5 minutes on this first question, I'll just provide some background. One of your colleagues has heard that there have been a number of people with fever, cough, and trouble breathing. They've been told that one of the older males passed away, and people in the village think it was due to the same illness that is affecting some of the others. He also had trouble breathing, a harsh, dry cough for a week before he needed to go to hospital and have mechanical ventilation, and he passed away in hospital. So what I want you to think about is what additional information you will need. So I'll go back to the scenario and leave it on the screen. But if you could divide into groups of 3 and just have a 5-minute discussion about what additional information do you think you'll need. Any questions?
Gibson, you could also let us know if the groups are ready to report back. Oh, Gibson and everyone in Oro, the RRT. In your manual on page 11, there's actually some tips about what Laura covered on how to verify an alert, if that helps. Hi, Gibson. Is everyone ready to report back?
You guys ready or? It's another application. No.
So everybody's ready? Hello, Oro. Do we have a group that can volunteer to report back? What type of information do you want to help with this verification process? Any volunteers?
Hi, Gibson. You're muted at the moment. There we go.
Hello.
Can we have a volunteer group that can tell us what type of information they want to help with this verification process? They've received a report from one of your colleagues.
Okay, Tim. Tim. Somebody come and respond. Because I'm in front of them. Yeah.
Can you repeat what you just the question that we will ask? Right?
Yes. Yeah, so here you've received some information from a colleague that there've been a number of people with fever and cough and trouble breathing, and you've received this information, and I want to know what additional information you would like.
I'll just try.
Yeah, please go ahead.
Following that, we will ask some relevant questions to the patient at TC in regards to that scenario. So, one of the questions we will ask is, where were you the last 14 days?
Great. So where were you in the last 14 days? I'm going to put this up on the screen right now. Where were you in the last 14 days is a great question. What other information do you think you would like?
Who were your contacts?
Yes. And are you asking this for all of the, so you received some information from, the colleague and there've been a number of people in the village. So are you wanting to know from your colleague this information, or you can't go out yet? So who were the contacts? What other information do you want to know
You asked for
from
the
your
age?
colleague? Yeah, the age of the people.
Yes, yes.
The duration. And the total number of people that are affected.
Yes,
Very
terrific.
good.
And the location of the place.
Yes, wonderful.
The duration of the signs and symptoms.
Okay.
Terrific. Any other ideas of the type of information that you would like to know?
There's any death of cat in the village?
Okay, this one.
No, that's one already.
Any deaths reported.
Drugs taken? Any treatment?
Great.
Any treatment? Provided?
Any village deaths of similar symptoms reported from home? Village deaths, yeah.
Wonderful.
This is really good, everyone.
You've really come up with some great ideas for this scenario. Actually, we've covered most of, yeah, you've really contacted your colleague again and you've asked them this additional information, and they have told you that so far there are 11 or 12 people that are sick, and the dates that they became sick. So they've told you this information that's on the screen right now. So you asked your questions and you've received some additional information. Can you tell me, do you think a rapid response team response is required, and why or why not? So you've received this additional information that there have been 11 or 12 sick people in 2 villages. So great job asking if another village has similar signs. You've received some dates, and it's quite a narrow date range. At first there were 1 or 2 sick people, and now there have been 8 sick people coming into the clinic. You have the new clinical signs. Actually 2 people died, so great job. I know somebody called out how many deaths, so really great job asking that question. The disease seems to be contagious, that the sick people have come from the same family group. The testing has not been conducted to diagnose the possible cause, and there's been some violence between the villages. They believe the disease is due to sorcery. So if you could have a little chat in your group of 3 people again, do you think an RRT response is required? Why or why not? So I'll just give you another couple of minutes to answer this question.
You guys need to think an RRT team is required here or not?
It's required
Required.
because of the scenario. There's a couple of those cases and already proven. So we really need to go there and do the testing. I think they have not done any, conducted any testing yet to diagnose the possible cause. So it's possible. We should go.
Discuss when they come on what not. Could we participate in otherwise I'm
Rapid response team. We have to dispatch.
Yes, sir.
Okay, what does everybody think? Is an RRT response required, and why or why not?
Yes.
Everybody agreed that the rapid response team should be deployed.
Great. And why do you think it should be deployed?
That's reported, and also the diagnosis need to be established, as there's already some people believing that sorcery is involved, and there are already some clashes in between two villages, so the rapid response team will go in and maybe properly diagnose the cases and maybe mitigate the problem.
Okay, wonderful. Terrific. So there's already some deaths reported. We have 2 villages involved. There's some talk of sorcery. So it's important to go in and investigate further and find out what's happening. Well done, everybody. So I'm going to stop sharing this screen. That brings us to the end of the presentation on knowing when when a rapid response team could be needed. Does anybody have any questions at all before I move on to the next presentation? You came up with some great ideas that I'm really excited by all of the discussion and the ideas that you're coming up with. So really well done.
I have a question.
Yes,
Yes.
there's a question.
I'm just asking, is RRT responsible for AFI?
Oh, sorry, can you say
I
that one
missed
again?
the question.
Is the rapid response team also responsible for AFI? AFI.
Oh, AEFI?
Yes, AFI.
It's
After
asking whether
immunization, are they also responsible? Are they also playing role in that?
I think it's varying province to province. Perhaps Dr. Anthony or Barry have some insight into that.
Yes.
They might not be online.
Oh, sorry, one more
Oh, there we
question.
go. Hi,
I'm
Dr.
here,
Anthony.
but what's the question?
The question was, does the RRT play a role in the AEFI response and surveillance? The adverse event.
That is an acute event following vaccination.
yes.
Sorry, adverse events. Is that what you're saying? Whether they play a role?
Yes.
Yeah, that's also varies. Yeah, it's possible. On a routine level, I would say no. But if there is an acute event following vaccination and those are reported, yes, there is nothing wrong in asking the RRT to investigate that. So yeah, the answer is possible, but that is not their routine role. Does that make any sense?
If I may add, hi, can you hear me, Barry? Yeah.
Yes,
Yes,
go ahead,
ahead.
Barry.
Yeah, the AFI is an unusual event, so that can be still classified as an event to be investigated by the surveillance team. Obviously, it has to come to the rapid response team because any event, whether small or big, whether it's from volcanic or it's from immunization or it's from oil spill, it doesn't matter. It's the rapid response team is responsible for all events. It doesn't matter what. So yes, it has to come through the team that now we have here, but specifically the composition of the team to investigate will be, you will opt for it. Like now we don't have the EPI program manager there now. Because it's a vaccine related, you must have an option members in the team. That's why we said it's open, but now we have that team that we specifically requested that makes up of the RRT. But depend on what event. Now we're talking about adverse effect following immunization. Then you need to make sure that the pediatrician comes in from the clinical perspective. The EPI program officer comes in, but the surveillance team lead still takes the lead because it's part of surveillance and investigation. Of course, the laboratory person, still everybody still plays, but you will opt for other people to come in. In this case, which will be the EPI program manager and the pediatrician, because if it is during immunization period, but now adults are involved too, so depends on who it is. In this case, will be the physician or the general medical doctor who's dealing with the general patient care.
Thank you.
Thank you.
Thanks very much, Anthony and Barry, for that.
Thank
Were there
you.
any other questions?
No, I think not at the moment now, so I can continue.
Great, thanks, Gibson. Okay, we'll move on to risk assessment, which, as Laura said in her talk, is the next step after you verify the alert. And take it away, Laura.
Wonderful.
And again,
Thank
everybody,
you.
we have a scenario at the end of this.
Can everybody see
Yes,
this
perfect. Yep.
at the moment?
Yes.
Oh.
Yeah, it's back.
So in this next presentation, we're going to talk about that risk assessment step. And what we want everybody in the room to be able to do is talk about the process of a rapid risk assessment and to be able to conduct a rapid risk assessment. So that's going to be your task at the end of this presentation. Now, in that presentation just earlier, I talked about a 3-step process. If you detect something unusual, how do you decide if you're going to take action? So that first step was triaging. The second step was verifying. And once you've verified and you have a genuine event, this last step, this risk assessment step, helps you decide what kind of response is required. Now, what exactly is risk? So on the screen, we have some people parachuting, and it's certainly a risk I haven't taken. But we need to talk a little bit about what risk actually is in the context of a risk assessment. There are many different definitions of risk. And it's used across all types of professions. So engineering, importing food products is really used in many, many different contexts, manufacturing, for example. So what exactly is risk? Well, risk is the combination of the chance that something will happen and the impact of an action or a condition when it does. So risk is the possibility that harm may occur when exposed to a hazard. This is a lot of new terminology here when we're talking about risk, but just remember it's about probability and about the consequence or the impact. Now, a hazard is something that is potentially harmful. So when we talk about hazards, we really are talking about something that could potentially harm you. It could be a virus, a bacteria, a chemical. And it could be something that's introduced into the water. It could be a physical hazard, such as fire or properties that are damaged after an earthquake. They can actually only be risk when there is at least something that can harm you. So an example of a risk is driving to work. You could be injured or potentially killed in a car accident. So the risk is reduced if you drive more slowly, because if you do crash, then your chances that you'll be injured are reduced. The crash is increased, the risk of a crash is increased if you drive to work by you're using a car that you don't maintain very well, you haven't checked the tires, or you haven't checked the brakes. So when we're talking about risk, it is the possibility that harm may occur when you're exposed to a hazard. So I'd like you to think about your normal day in the office, in the clinic, and at home. And if you could call out some examples of hazards you may encounter in your regular day. So if you can just yell them out. I've already said one of them, and that's, driving potentially is potentially being in an accident is something you may encounter. What are some other hazards you may encounter in your regular day?
Work-related injuries.
Sorry? So hazard is something biological, it could be a chemical, it could be a physical hazard. So being in a car crash, potentially a hazard. Sorry?
Workplace injuries.
Injuries. Yeah, terrific. What could injure you at your work?
Needle stick injuries.
Needle stick injury. Yes, that's a great one.
Fire.
Fire. Yes.
That might occur from the smokers.
What are some other things? What about the people in a clinic? What could be a hazard in a clinical setting?
Infection.
Yes.
Cross infection.
Yeah, cross infection. Great. So a pathogen that you're exposed to in the workplace, that can be a hazard. A needle stick injury and fire. They're great examples of hazards, everybody. Some others you may encounter, for instance, if you're chopping things in the kitchen, you may, knives a hazard that you may encounter. So different types of hazards that you may encounter, but you've given some really great examples. Now, can you tell me, for a needle stick injury, what are some risks of harm that may happen to you if you get a needle stick injury?
Why I'm infected.
Yeah, you may get infected.
Hepatitis or HIV.
Yeah, you may get an infection. What about a fire? What are some risks of a fire?
Burn yourself. Burn yourself.
Yeah, burn yourself.
Burn yourself, but
And
No shown information.
I'm missing those things. I can't hear everybody. Yep, something is. Yeah, so you can burn yourself, or you can actually lose things that are important to you. Maybe maybe some things in the office, some equipment. You could lose your house. And so there's some of the consequences that you may encounter. So a hazard is something harmful, and the risk is a possibility that harm may occur. So it's a measure of the likelihood and the consequence. So certainly, you know, potentially a fire is fairly uncommon. It's not going to happen very often, but potentially the consequence, if it does happen, could be quite severe. You could lose, you could become burnt, you could die, you could lose your house. So risk is a combination of the chance that something will happen and the impact of when it does. So when we do a risk assessment, we're undertaking a systematic process where we gather, assess, and document the risks associated with one or more hazards, and we assign an overall level of risk. So this sounds really complicated, but we're going to go into it in a little bit more detail. And you've done some of that already. You've talked about some of the hazards that you encounter every day and some of the risks that may result. In public health, one of the most common things that you will do is a risk assessment following an event being detected. But this isn't the only time that you can do risk assessments. You can actually use it for to support you for a variety of decisions that you're going to make and control measures that you may implement. But our focus today is risk assessment following a detection of an event to help you decide what actions that you should do for a public health outbreak or other type of public health event. Now, risk assessment is part of a cycle where you detect the event, you conduct a risk assessment, and then you implement some actions to try and reduce that risk. At the center is something called risk communication, which I know there's some people who are experts in this and will do this as part of their job in the rapid response team. Risk communication needs to happen all the time as you're doing that risk assessment. It's a two-way exchange of information about the hazards and their risks and possible options that you can use to control those risks. Now, risk assessment, I wanted, this was mentioned a little bit earlier in the opening presentation for the day, but under the international health regulations, it's actually a requirement that that every country has some capacity to undertake risk assessment. And so what we're doing today is helping fulfill your country's international obligations to have people who are trained and understand the risk assessment process. Now, internationally, there are actually requirements to notify if at least two of these criteria have been met, notify the World Health Organization. So I'm not going to go into it in detail because it was spoken about a little bit earlier, but I'm interested to know what surveillance and response capacity, and this is a requirement of the international health regulations, what surveillance and response capacity has been developed in Papua New Guinea? You can just call out the answers. Maybe it's frozen.
Gibson, can you hear us? Oh, there we go.
I think you're on mute, Gibson. Great, Gibson. So can you tell me what is some surveillance and response capacity? Does anybody have any examples of some capacity that's been developed in Papua New Guinea?
Or even Oro province.
Laura, sorry, your audio is going a little bit loud. We can't hear you clearly.
Can you hear me better now? Is it okay?
Hello? Hello? We
Hello,
are
can
unable
you hear
to hear
us?
you clearly.
Okay.
Maybe I could help in this question. I think what John is asking is what systems have we developed, or what activities we've undertaken in terms of improving and sustaining surveillance system in PNG. I think as far as when the surveillance is in PNG is a very fragile. It's not up to its system, but we've developed tools like the outbreak manual is one tool that we have. I think it's the second edition now to assist the frontliners and also those who are involved in public health surveillance system and response system to use as a guide. But at the professional level, we also undertaken the field epidemiology training in 2013, basically to fill in the gaps and also to strengthen the surveillance system and also fill in the expected outcome of investigation within the time frame, and also completeness of report. And I think we have seen, and I have seen some significant improvements when we got field epidemiology training graduates out in the field and responding to outbreaks instead of waiting the national department to go down. So that's some of those things we have undertaken. And I think also in general what we said earlier is about the establishment of provincial emergency operations center, and our plan was to see that we have a team like this now will undergoing this training. It's supposed to be full 4 or 5 days, but we got on to 2 days. So those are some of the things we have done, and there's still an ongoing syndromic surveillance system in the country, and we have we have improved from a paper-based to an ODK, platform to improve in terms of participation and also timely. And I think we're trying to move away from, ODK to what do you call it, the core data. But that's a system that we have just to make sure that we are getting the events and capture the most likely events that would cause outbreaks. And this is parallel to the National Health Information System, because the National Health Information System cannot give us what we want. For routine surveillance, for outbreak detection, we want timely. We want quicker action. The report has to come quickly. But in terms of coverage, we still not there, and also in terms of timely, not there. So hopefully, with the experience of COVID and moving away also to further strengthen the ODK platform and also the Go data, we can be able to expand from what used to be only the provincial level to further down to district and health facility level. So that's on the pipeline. That's we're going to do that. I think, but most importantly, it's a knowledge and a skills and understanding of what surveillance means across the board by health workers. Health workers meaning from the top SSMOs down to the very community health worker. There needs to be a lot of training and a lot of energizing in terms of making them aware that apart from the routine monthly reports of the patients or diseases that we see through our normal outpatient, there are these situations where some of the symptoms and the surveillance that need to be reported urgently, even when we see one, or even we don't see it, but we hear rumors, and also other symptoms that are included in the syndromic surveillance system. That's completely separate reporting system than the routine monthly ENHIS. So we got the combination of routine syndromic surveillance and the event-based surveillance all in one. Event-based surveillance is not a paper-based. It's it's a rumor surveillance. You can get that from radio, TV, newspaper, or from One Talks, or even community leaders. So it's a combination of several stuff, but we've not been able to do that in a more systematic. But things are happening at different platforms and different approaches. So hopefully, the next 10-year plan should be able to bring that together, because we are putting in a strategy to develop what they call a public health institute, which should house all the reporting systems, e-insights plus syndromic surveillance, plus program-based reporting system like TB and HIV, malaria.
Wonderful. Thank you so much for that detailed summary, Barry. Do we have Oro back? Can you hear us okay, Gibson?
Yes, yes.
Yes. So really, that is an incredible description of what's being done across the country to meet the requirements of everybody in country, but also under these international health regulations. We have FET-PNG, a rapid response team, some surveillance, syndromic routine surveillance, event-based surveillance, and what you're doing today, learning about risk assessment, that's also fulfilling these requirements and hopefully enabling you to better identify what's required when you're required to respond and what actions that you can take. In terms of the steps of a risk assessment, the first thing you're going to do is assemble the team. And again, this is just the same as for very similar for outbreak response. You're going to get people together who have expertise in the disease that you're dealing with or the situation that you're dealing with. And it could vary depending on the different situations. So as an example, if there is a likely COVID-19 outbreak in a village, who do you think you would want on, you've heard some reports of respiratory disease. Do you think it could be COVID-19, it could be influenza, it could be something else? Who would you want to be part of this risk assessment process to determine if you need to respond or not?
Hello?
Hello, can you hear us?
Yes, data analyzer to be part of that team.
What was that?
Hello, I'm saying data analyzer.
Yes, data analysis, so an epidemiologist. Who else would you want to help you? Clinician, great. Lab? Yes, terrific. Who else?
Social mobilizer.
I couldn't quite hear that one.
Social mobilizer.
Yeah.
Social mobilizer.
Yeah.
Terrific. So these are the people that you would want to help conduct that analysis. Now I have some criteria on the screen at the moment and some suggested roles, and you've covered a lot of those off. So really well done, everyone. In previous presentations, we talked about some of the types of events that you may need to respond to: an infectious disease outbreak, a natural disaster. Some of these things could be in remote areas or involve certain communities. So really bring the people in who have the knowledge that will be able to help you with this decision-making process, because risk assessment is all about making decisions. It's really important that you involve people, with different types of expertise, because it can be really easy to miss a risk or think the risk is low when it's really high if you don't have that expertise in the room. So next we want to look at the situation and the exposure and the context. Again, we're going to talk about potentially some of the ways that you can find information to help you complete this risk assessment process. We assign a level of risk based on the situation of the known or suspected hazard, the possible exposure to the hazard, and the context in which this event is occurring. And so we use all of this information to determine how high the risk is. So we talked about some of the risks before, potentially the fire, it's a low chance, but a high consequence. So we may say at home, the risk of fire may be, medium to high. And so what we're doing is we're assessing how likely this risk is to have an impact. And the first thing we need to do is consider the situation. So sometimes you will know that straight away, you'll know you've heard from the lab and you'll know what the diagnosis is, but sometimes you won't, and you'll need to consider all different types of possible hazards that may be occurring. And for most of you, this will be different differential diagnoses of infectious diseases. But, sometimes you will respond to other types of events as well that may involve chemicals or toxins. You can gather this information, and we gathered it a little bit earlier, information about the cases, the number of people affected, how severe the illness is, and when those cases occurred. So all of that information you actually identified in the last presentation. You did a terrific job. So in this first step, we really think about the situation. So you've been notified of a media article which was reporting a large respiratory outbreak. And so what sources of information could you use to assess the situation? We've already talked about this a little bit earlier, but what are some sources of information? To really assess what the situation, what's happening with the situation. I can't hear.
You get to the people on the ground and get some further information by asking. The other one would be to make phone calls to those that you may know of their contacts in that particular area and get further information.
Great, terrific. You mentioned it in an earlier presentation as well. So what other information can you help to assess the situation? What's actually happening? What sources of information? You mentioned it right in the first presentation. It has to do with looking at that baseline information.
What information might you have at the PHA?
Monthly reportings by health facility in there. Can also
Perfect.
Get in touch with the health worker who is closer to the particular place where there is event. The event is been reported, so can get further information on that.
Wonderful. Great. So you can look at your records, your surveillance systems, and you can speak to some different people. That's really terrific, everyone. Let me just go to the next, I don't know, Perfect. Oh, I just went back to the start again. I've done that a few times. Sorry about that. Okay, we've assessed the situation. Now, if we can assess the exposure. So what we're trying to do here is try and estimate the number of people that are known or likely to have been exposed, and also the number of people that are susceptible. So the types of information that we require are exposure sites,
Sorry, Laura,
date and
we can't
time.
hear you clear. It's clear.
Okay, no problem. Let me know when your internet comes back.
On and off.
Great, I think you might be back. Can you hear me okay?
Yes.
Great. So when we do the exposure assessment, we want to know how many people are likely to have been exposed to the hazard. That could be the bacteria, the virus, the chemical. And we want to know the number of people who could be susceptible. So for a respiratory outbreak, that could be the number of people likely to be exposed. We could be talking about immediate family members, people who attended the same venue, people in the same hospital, and the number of people who are susceptible. It could be everybody who is in the local village, in the local area, that could be potentially infected by the outbreak. So we require information about the exposure sites, dates and times. We require information about how the hazard is transmitted, so how the bacteria is transmitted, how the virus is transmitted. So can you tell me, again, we've been notified of a large outbreak, and you want to know how many people could potentially have been exposed for this respiratory outbreak, and how many people could be susceptible. So you're interested in possible exposure sites, the dates and times, and the modes of transmission. What sources of information could you get these information from?
Just the exposure.
So you're after the source of information for exposure sites, modes of transmission, to determine the number of people that have been exposed and who is likely to be susceptible. Where can you get this information from? People on the ground. Great. Yeah. How about the modes of transmission of a disease? Where would you get that information from?
The people in the infected area.
Yes. Terrific.
The travel history of the patient or the victim.
Wonderful. Yes, you can get information about, certainly about contacts through the travel history of the patient. You can identify how many people are likely to have been exposed. Any other sources that you can get information about how transmission can happen? About how many people are likely. What else?
Look at the outpatient figures from the traveling from the local facility, health facility.
Great. So you can look at surveillance information and you can look at health records. You can look at, you can collect the travel history of the patient. You can find out the number of people in the infected area, and you can contact people on the ground. That's great. You can also find out about the ways that the disease is transmitted by looking up some literature or other sources of information that can tell you about how the disease is transmitted. So for some diseases which you may not have encountered before, you may need to look up some published research or some presentations from people about how exactly that works. But you've really identified some great ways to find out who is likely to have been exposed and who is at risk of being exposed, who is susceptible to that. So that is the second part. The first part is looking at the situation and what is happening and getting some more information. The second part is looking at exposure. And the third part is thinking about the context. So here is where you can think about the environment in which things are taking place. So some questions that you can ask yourself are if vulnerable populations are affected, are there factors that could affect further transmission? Are there political sensitivities? Are there enough resources to respond? So with this information, first of all, you look at the existing situation. Secondly, you look at the exposure. How big is the outbreak potentially? How big could it become? And third, you're looking at the context of this particular outbreak. Is there some sensitivities? Is it in a remote village? Is it a particularly vulnerable population, maybe elderly people, maybe children? So where would you get this type of information from? About the context, so the environment in which the event is taking place.
I join. Can I interrupt for a second?
Yes, please go ahead.
Yes.
Barry, sorry, I have to step out a little bit because we have a very important meeting at 3 o'clock this afternoon. Next 30 minutes, so I'll see you all again tomorrow morning. Tomorrow, please. Thank you, Loibla Stawatem. Tomorrow morning. Thank you.
Thanks very much, Barry,
Thank
for joining.
you.
Can
Yeah,
I also
thank you
jump
very
in?
much.
Oh, thanks, Dr. Anthony.
Yes.
We'll see you again
Yeah, I
tomorrow.
will also leave in about 10 minutes.
Okay.
I have another meeting at 3. So it's been a great time. And I congratulate both the participants and the facilitators for a great job well done. So thanks a lot, and see you maybe tomorrow also. Thank you.
Wonderful. Thank you so much.
Thank you.
So for everybody in Oro, where could you get some information about the context? So remember the context is about the environment in which the event is taking place. There could be social factors, economic factors, ecological factors. Where can you get this information from?
Local community leaders.
Local community leaders, fantastic.
Councillors and church leaders.
Where else? How about ecological information? You know, about if it was, say, dengue and you wanted some more information about the insects or the climate? Where would you get this information from?
Environmental health or the various
Reports
reports.
from the monthly reports.
I missed that.
Speak up.
From the environmental health.
Yeah, great. So from environmental health, from maybe you can get some rainfall data, information about insects from entomologists. What about some more information about the communities involved? What types of information would you want about the community to work out if it is the size of the population, about how the community behaves? Where would you get this information besides the community leader? Who else could you ask? Yeah, other government offices. You can also wonderful. Great. Okay, so some other places that you can get this information, you can get maps of the size of the population. You can also look at data from different government offices. You can look at actually satellite images as well, can help you determine this type of information, and the epidemiologist can help you really understand what all of these information sources mean. So if I go back, we've looked at the situation. We understand who is infected, how many people, we have an idea of the exposure, how many people, how big the outbreak could be, how big potentially the outbreak could spread. We have a look at the context of the situation, the communities involved, and some of the particular contexts of those communities. Are they remote? Are they elderly populations? And we gather all of this information into an overall assessment. And that overall assessment is in your guide, and we can have a look at a little bit later. But we use all of this information to assess the overall level of risk. So if we consider, after collecting all of this information about an outbreak, that the risk is low, then we manage it according to the standard response protocol. But if we consider that the risk is high, that means that we think the disease is a serious threat to public health, that it could cause serious illness or deaths in a community, then potentially we need to activate the rapid response team. So what you do as a group, you gather together, you collect information about all different types of things, about the situation, about the potential hazard, the potential infection, about the community, about how big the outbreak could be, about how far it could spread, and you gather all of this information into an overall level of risk. Has anybody seen, this is called a matrix. Has anybody seen something like this before? Can you yell out if you have?
Yes, yes.
Yes? What did you use it for? Outbreaks. Terrific. Outbreaks and response. Wonderful. So you've seen something like this before, and the way that you come to that is through collecting all of this information and working together to assess an overall level of risk. That is what is the chance that it's going to spread and get larger, and what is the impact if it does? So the level of risk, if you think about it, it's about the chance of something happening that's bad, that can cause a public health threat, and then the impact if it does. If it spreads, how are people going to be impacted? The next step is we have a look at completed actions and then planned actions. So when you've done a risk assessment, there may be already some measures in place that have been implemented. So you may have already, some sites may have already been notified that there is a possible outbreak. Some advice may have already been provided. You can look at what has already been done to help respond to the outbreak. How much has been communicated to people? Have the community leaders already been engaged? Is there already some measures in place to respond to that outbreak or that threat? And then finally, you can look at what you can do to prevent further spread. So these could be additional actions that you might want to take. You may need to identify additional sites to notify that there has been a possible outbreak and spread. And you need to think about what advice you will provide them and whether or not the rapid response team will be deployed. Remember what Barry said earlier, sometimes you can provide advice over the phone, but sometimes you may need to decide that you need to go as a group to the particular village, to the particular healthcare center, and investigate further. You may also need to think about the population that's been exposed. So how is the risk going to be communicated to them? And how will community leaders be engaged? So in terms of activation of the rapid response team, we know that a rapid response team should be activated within 24 hours of notification of an alert, and that during COVID-19, you need to respond if a person fits the case definition for COVID-19, if a hotline is verified by the surveillance team, if there's a suspected case from a health facility, report from a healthcare worker, or an unusual increase in the ILI or SARI data. So now we're getting to the scenario. If you remember your scenario from before, there've been 11 or 12 sick people. Those people were sick in March and April. And what I'd like you to do is decide what additional information that you need to conduct a risk assessment. So you've assembled together as a team, you're in your groups of 3, and I'd like you to think about what information you need about the situation, about exposures, and about the context to determine the overall level of risk. So I'll leave the scenario up. If you can have 5 minutes to think about that, that would be terrific. Any questions?
Maybe one group can do exposure, and one can do context, and one can do situation, and report back. Might be easier.
Thanks, Joe. Great suggestion. So yeah, if one group can do the situation, what if additional information you'll need, one group can look at the exposure and one group can look at the context in 5 minutes. Thank you.
Thanks, everyone.
Which other groups want to do situation? Exposure, and what's the other one?
Situation, context, and exposure.
Context. The other one is the context.
Context.
How many groups do we have?
What? 3. Situational assessment, cost assessment, and conducted. This is on page 30. Page 30. This is the questionnaire assessment. Group was verified.
How is everybody going?
Yeah.
Another minute or two, or you're ready to report back?
Tim, responded, please.
Okay. Maybe if we can get everybody reporting back. I don't want you guys to stay too long after 4 o'clock. So if I could get the people that thought about the situation and what additional information they need, can you tell me what additional information would you like to have about the situation? Are you ready? Can you hear me?
Okay, Tim. Yes.
Yes? Are they ready, or should one or two more minutes?
Come on, team. You guys ready to answer? Respond.
Feel free to come up to the laptop.
Okay, come closer.
So if we remember again, so far the information we know is that there have been 11 or 12 sick people. Those people were sick between March and April, and that they have had coughing, some trouble breathing. 2 people have died. There are 2 villages. There's been some violence between the 2 villages, and we haven't got any testing results so far. What additional information about the situation would you like?
The particulars of this person who is sick, like his age and all his basic information of sex, age, and I also would want to know of whether he has traveled out of the province or from out of his particular village in the last 14 days.
Great. Any other additional information that you would like to have about the situation to help you with your situation assessment?
I would also want to know when actually the patient, that particular patient developed those signs, symptoms, onset of the problem that that particular patient developed. And also find out about other medical problems he or she may have at the time.
Sorry, what was that?
I'll also want to know about this or her other medical problems.
Yes, yeah, great. What about the situation in terms of the outbreak? So we know that a village is infected. What is there any other information you would like to know about the timing, the location, anything else to help you make your decision about what the situation is? Are you sure it's an outbreak? What other information could you need to help you make your decision?
To find out whether is there anyone in the village or within the family member who has the similar
yes,
symptoms.
Terrific. Wonderful. Okay, terrific. So with the situation, additional information could be more information about the cases, if other people have similar symptoms. You could also think about what disease is causing all of these symptoms. So another thing to think about is, has the laboratory received any test results? Do you have any more information about the specific hazard or the specific pathogen itself? Great. So we've collected some information about the situation. Now we're thinking about the exposure assessment. And we want to know who could have been exposed and who is susceptible. So if I go back up here, who has been likely to be exposed, and who is susceptible. So what additional information do you need to help you get to help answer these questions? Can I have the team come up that that did the exposure assessment?
One team come and say something, please. Exposure. Secretary, I thought you were coming and you're going out. The exposure, yes.
Exposure assessment,
Additional.
at the time, additional information I would like to know would be, I would ask for what age group may likely at risk or exposed, I mean, they're susceptible to actually the person who has been infected. I would be interested in the age group.
Wonderful. So what age groups are susceptible, and who has been in contact with the cases?
Yes.
Age group and also gender.
Yes.
Oh, sorry, we missed that. Are you able to come closer?
The suspect cases. Any other suspect cases?
Yeah, the number of suspect cases.
Perfect.
And also find out how many more are going to be exposed.
How would you find out about how many people have been exposed? I think it was mentioned a little bit earlier in the situation.
Ask around, ask the people on the ground, ask the community.
Yeah.
Of anybody who has the similar kind of symptom back in the community.
Yeah.
What
would you want to know about the pathogen itself? You don't know what is causing this yet, but what's some information that you would like to know about the pathogen that could help you answer how many people have been exposed?
Identify the area whether it's a chemical or pathogen, and then decide who may be harmed or how.
Exactly. So we know that different pathogens are spread different ways. So if we think about, if we can identify the pathogen and work out how it is being spread, that is the modes of transmission. Other types of information that can help us work out how many people are likely to have been exposed. We can also, your epidemiologist can also tell you some information about, and the clinician about the incubation period, so how long it takes to develop clinical signs. We can look at how quickly the disease is escalating in the community as well. Is it just one case and then another case a few weeks later? In this scenario, we had a couple of cases, but now there's all of a sudden been 8. So it looks like it's spreading fairly quickly. So information about the modes of transmission, about the potential for transmission as well of the particular pathogen. And that will vary from pathogen to pathogen. Measles is a lot more infectious than some other pathogens. Now, the last thing we wanted to do is look at the context of this particular outbreak. Can anybody tell me what additional information you would like for the context to be able to assess the context. Can I have the group that looked at the context come up?
The origin of the pathogen or the where were they in the last 14 days?
You come a little bit louder. Yeah, the mask. Yeah.
What information would you like to know about the villages?
There's one information that I would be interested also is the population of the village.
Yeah, the population of the village.
The whole population, and out of that population, how many are infected? And then I would already be working out the probability of how many to be infected if that disease.
Yeah, great. Yeah, perfect.
And then if it's a coronavirus we are talking about, then I'll be looking at the context, the past travel history of the context.
Great.
I will establish, or I will identify where this infection came from. Is it within the village area, or is it someone coming into the village and infecting the people?
Perfect. Great. So we can have a look at some of those economic factors about human behavior and how the disease was likely introduced. And we also thought about the size of the village. We also mentioned that that the villages, there'd been some violence between the villages. So we might want to know something more specific about how the villages resolve conflict, or some history about each of the places, each of those villages that are involved, for any cultural factors which may be of interest. Now we're a little bit behind schedule, so that was a terrific session. It's a very complex area, but it's really important that you know how to gather all of this different type of information and put it together to come up with an overall assessment of the risk. And once you do that, you can work out what actions you need to take using this matrix. So if you determine that the overall level of risk, that is the risk to public health, is high, then you know that the action that you need to take is an RRT response. If you gather all of this information and you think the risk is not very high at all, then you know that it's managed according to your standard protocol in RO. So I just wanted to know if you need a quick 5-minute break, or if you're happy to go into the next session straight away.
What do you think, Gibson and team? Would you like a break?
Okay,
We have about 1 hour left.
Just 5 minutes break and I should be back.
Yep. Okay.
Yeah, 5 minutes.
Come back in 5 minutes. That would be great.
Yeah.
We have Dr. Abel here. We have Dr. Alois, and we have Tommy as well, who are very, very interested for the community engagement session. So really looking forward to that. We'll see you in 5 minutes.
Okay. Tim call what I enter. Only water. Yeah, just drink cold only water. Look how much
Hi, Abel. Did you want to check anything? Your slide looks great. I think we've had good audio with you all day.
Yeah, John, I'm not too sure whether it's just showing the slide or whether it's showing the
It's only
talking.
showing only showing the slide. We can't see any
Okay.
notes. Yeah.
Perfect.
Yeah. Excellent. Thank you so much for presenting. Really looking forward to this.
No problem.
And so, Abel, I think we'll see how we go, but I'll probably move IPC till tomorrow because we want everyone to be able to leave at 4. So that gives you plenty of time to present this communication plan, community engagement, play the video, and have a bit of a discussion. And then we'll just see where we're at. But we'll probably just move IPC till tomorrow. Just because of being behind.
Yeah, we'll see how much time I will get, but I think the communication piece should kind of run through quickly.
Yeah, yeah, that one's very fast, and even community engagement, we might be done by 3:30, and then I can just do a very quick IPC and finish it tomorrow. We'll just see how we go, but yeah, as long as we get everyone out by 4, I think it's fine. But yeah.
Yeah, and in the community engagement piece, I'm not too sure. You might also come in the discussions and
yeah,
and then yeah, we can facilitate that together. But yeah, we'll see how it goes.
Yes, for sure. And we have Alois here. We have Tommy too from so they both are in our video. More than welcome to take part, Alois and Tommy. We'll introduce you again, and we have 3 questions in the community engagement presentation where we ask them about their community structure and who the key leaders are and the stakeholders they should engage, and any barriers they have come across and any successful methods that they've used. And would be lovely to hear from you again in that session. James, are you still on, or did you have to go to a meeting?
Yep, I'm here, Joe.
Great, thanks. So yeah, so James will be here as well, able to help with the session.
Yeah, do you have the link? I'm just trying to find the YouTube link and I can't get it on this computer, but maybe we can just post it into the chat and enable when it's time for the video, just instruct Gibson to go to the chat and just watch it from the link, I think. My experience trying to run a video through Zoom is not very good.
I can try now, and you just let me know.
Yeah, we can try it. Just copy the. Oh, you got it there, Joe. Try when you click it. I think there's an option to play the video. There's a video option on Zoom, I believe, and it gives a little bit better audio.
Sorry, it's sharing on the wrong screen. I'll try again. Here we go. So can you hear that as well as see the YouTube?
No, there's no audio, and it's
No
quite
audio.
jumpy. That's what it
Oh,
typically does. So
okay.
yeah, let's get them to
Play it in Oro.
yeah, they can just play it in Oro,
Okay.
and
Yeah.
then they can just tell us when it's finished, or we'll probably hear it anyway.
Okay,
Yeah,
that's good to know.
Very
Yeah,
jumpy, very jumpy.
it's good to know because I have a couple of videos for IPC. So
Oh, okay.
so that, I mean, it doesn't matter. It's not the end of the world. Maybe he can play in Oro. Yeah, we'll think about it.
Yeah, if there's no audio and it doesn't matter so much if it's a bit jumpy, you can do it through Zoom.
Okay.
But can you just send them the link, Joe?
I can't. So they were actually in the PowerPoint. I took them from WHO PowerPoints. They're not links. They're videos in the PowerPoint slide. So I just got to think about that.
Oh, the one you have up right now, is that one of them?
Oh, this is one that I can just play on YouTube. I found that one.
Yeah, you can send that YouTube
Yeah,
link.
it's only the hand washing and the donning and doffing. I'll see if there's some YouTube ones. Yeah. But looks like we might move eyepiece. I might be able to cover 20 minutes, and then the rest tomorrow. We'll see how we go. I want to give lots of time to community engagement, especially because Tommy has joined and Abel's only available today, and Alois. So nice to see you, Tommy. Thanks for joining.
Thank you. Thank you for inviting me.
You ready for the big premiere, Tommy?
Yeah.
Yeah. We're launching your career, your movie career today. Yeah, you'll be up for Oscars.
Yeah, thanks for sharing that, James and Joanne. Was really nice. I looked through it and I was, I should have, as always, like you give your own feedback too.
Yeah, no, you did really well.
Really nice.
You did really well. You got some great captions, and Alois is on there, and Bernie. So it's good.
It's really nice. I mean, at least we have some like practical things there.
Absolutely. And very inspiring, I think.
We can
great.
improve in our next version, I guess.
Yeah, I'm interested to see what discussion we get after the video, because both you and Alois are on. So be good to see what questions might come up, and it's good.
Nice. Are you having this session over like yours, like the participant of Oro province, right?
That's right. Yep. So the Oro RRT is what we're training today. Who we're training today, and then we have representatives from WHO and NDOH on the call as well.
Nice.
So the plans are next week we actually go to visit Alois in Bougainville and do a training in person there.
Oh, nice.
And then a couple of other provinces after that, and we hope maybe to get to Oro in person towards the end and do an after action review and see how the training went and what they applied into their workplace and what additional needs they might have.
That would be really nice to be there in person. That you have different experience and like get to know people by name and just.
Yep. Yeah, I think this blended approach is really nice. It's always good to do the in-person, but to do either the first one virtual or the second one virtual, and then face-to-face, I think could actually work really well.
It's really nice.
Yeah.
Been trying to catch up with my classes too, like during this June, and so trying to get used with using Zoom and stuff. So
the internet's held up well for us today.
Yeah, after all the issues in the morning, it's been great.
Yeah, a bit of a slow start, but I think that was telecom we were using instead of Digicel.
Lesson learned with telecom.
I see.
Now, Digicel seems to be holding up pretty good.
Really nice. Are they using like data from their phone or like they
just data on a phone? What's your internet, Tommy? Is yours a permanent connection, Wi-Fi connection you have, or?
Yeah, I'm using Wi-Fi. We have like a small dish just outside of our building, so that we're using like our own dish. So it's really nice. But
that's good.
We don't have any.
Do you have a limited number of gigabytes per month, or is it unlimited?
And I think unlimited. So you just pay for like monthly.
Yeah, that's good. Huh. So you put a satellite up, a little satellite dish, and you get the internet through that.
Yes.
Oh, excellent. And it seems to be quite good speed.
It's working really well here.
Yeah.
So we might hoping to put another one like in the future. We'll put another one in the really remote area that we can connect.
Wow.
Yeah.
That's great. Yeah.
Really nice. Last week we had a ranger evaluation workshop with the TB, so it was really nice to have them come in here and share about their story on like working with TB patient on TB case finding. So it's really nice.
Yeah, that sounds great, Tommy.
Yeah.
We'd love to have a presentation about that. You know,
sure.
There's some examples of engagement. Yeah.
I'm happy to share that with all of you anytime.
Great.
Yeah,
okay.
It's really inspiring work that the TB Rangers are doing with the tribal group. So similar with what we want to do with the community engagement, but that we go down more to the tribal level. So really interested and I'm impressed by their work. And
Oh, terrific. Maybe there'll be time in the discussion today. You can talk about it. It'll be inspiring for everyone in Oro. So that'd be good.
Yeah.
Hi Gibson, is everyone back? Abel, did you want to share your slides? Great, looks good. At the moment, Abel, we can't see any notes. We just see the slide.
Okay, that sounds good.
And still just the slide. No notes. Okay, Gibson, ready on your end? Still some settling in, I think. Just let us know, Gibson, when we can start.
Yes, we are ready.
Oh, great. Thanks very much. Okay, so everyone, we're going to start this session, block 2, which is preparing for the field. And this will cover communication plan and community engagement. We'll see about infection control. Might do that tomorrow. So our presenter will be Dr. Abel Yamba. He's a FETP graduate and one of our, a great part of our program and one of our assets and experts. We also have on the line Dr. Alois, and we have Mr. Tommy. So Alois is based in Bougainville, and he will feature in the video that we're going to play, where we interviewed responders engaging with the community and where they talk about their experiences and their recommendations. And Tommy will talk about his experience in Solomon Islands. And during the discussions today, they will take part and provide any guidance and answers to any questions. So without further ado, Abel, please go ahead and present.
Thanks, Joe. Can you confirm that you can hear me clearly?
Yes, I can hear. Gibson, can you hear Abel?
Thank you, yes.
Great.
Okay, thank you very much, John, for the introduction. As John mentioned, I'm happy to take you through the first few slide sets within the second block. Particularly, we'll be covering with me communication plan and communication engagement. First, we will cover communication plan, and I think this is vital to have in place during the rapid response teams when they're initially kind of planning to, launch out into the response. But even outside of the response, during day-to-day work or even at your work at the provincial health authority level, it is very important that you kind of have a plan. So here are some considerations for the communication plan between the rapid response team members outside of a response. And I think it is important to note that there has to be some communication or ongoing communication that happens within the team members to keep the team spirit alive. Because if you kind of drop that outside communication, then you will see that when there is a real emergency, trying to mobilize and get everybody together takes a little bit of time. So I think rapid response team members should arrange a dedicated time to regularly meet, and that is to evaluate surveillance data as they are coming in, discuss known or predicted public health issues within the province, keep informed of public health emergency issues within the region, and also rapid response team members should keep each other informed of and participate in continued professional development opportunities. One of the team members might be informed by one of his colleagues somewhere else that there is an opportunity, and when that happens, it's good that the member of the team kind of informs the other members as well, so they kind of participate in that kind of a professional development opportunity. And also the rapid response team members should keep each other informed of their availability so that backup team members can be arranged in the event of an alert or a response. So here is a question. Does your rapid response team have a communication plan outside of response or during response? I guess you will be in a better position to respond to this question after this training. But I want to ask the audience, prior to this training, have you ever thought about communication in general in an emergency response? The oral team?
Yes.
Yeah, communication on a daily basis, like communicate with each other, but not so much of in the form of a plan.
I see, thank you. And I think it is also important to kind of know that the concept of rapid response teams, probably not really in a structured manner, but there is in one way or the other. Most of the provinces do have some kind of response teams there, but I think the idea of this training is actually kind of formalizing what the team should look like, and make the structure embedded within the provinces. So that's important to know. Now, after considering plans for communication outside of a response, here are considerations for communication plan during a response, including communication on the 3 levels. So on the screen, you can see communication up, communication across, and communication out. So all of these 3 levels of communication are extremely important for rapid response teams to be effective in the field, and we'll see why that is. So let's look at each of these levels and what they really mean. Communication out. So let's look at communication up, which means reporting up to senior management, those above you. For example, for your case, it will be the PHA management, and sometimes even reaching out to Barry or the Department of Health. It's important to keep your leadership informed of the rapid response team's progress during a response, because I think they can make important decisions quickly if they're well informed. The frequency and the format of communication is something you should decide and be clear on before going into the field. And this is something you can discuss outside of a response. Usually a situational report, or sometimes we call SITREP, is used to communicate that. And we will cover this in the SITREP session tomorrow. The rapid response team lead is responsible for communication hub. So he or she is responsible for sending the SITREP. However, the team working together should prepare the SITREP report together. All team members might contribute valuable information about the day's activities. And this brings us to communication across. This means communication within the rapid response team itself. It is important to kind of support open and frequent communication between the team members. Team members need to speak up when they need support of any kind, technical, mental, emotional. So it's also important to realize that some responses kind of pose a lot of challenges, both challenges and stress in terms of your mental capacities to endure stress that you endure. It is good to it's good practice to create a buddy system, pair 2 team members to check on each other. It is good practice also to meet as a team first thing in the morning to plan the activities of the day, and again in the afternoon or evening to review the day's activities. It may be necessary to call stop work meetings if urgent issues need to be discussed as a team. In this case, all team members stop work and come together for a meeting. Ultimately, at the end of the day, the rapid response team decides on the communication plan within the team when in the field. Are you following me so far?
Yes, we are with you.
Okay, very good. So finally, communication out. This means communication with the community and the stakeholders you are serving as a rapid response team. It can include media interviews, village meetings, organizing meetings through the chief or the church, public health messaging, community engagement, and so on. We will go into depth about community engagement and risk communication in other training sessions, but it's important to remember when to communicate out. This kind of builds trust, and this kind of ensures that there's transparency when you're communicating with the community, and everybody, even in the community or those whom the service is kind of designed for, they will take see as a show of respect. And so I think at the end of the day, they will all contribute to very good results and you responding on time. So this is the last slide. Finally, in your rapid response manual on pages 18 to 20, we have included information about the communication plan and a template for you to complete as a team. So you can basically go through that, and if you have any questions, you can ask any of us. But for this session, I hope it was clear. It's actually a short session, and we can entertain 1 or 2 questions if there is any from the team in oral.
Communication questions. Any team with this short presentation.
Okay, very good. So I'll jump over to our next session. That will be on community engagement.
Thanks a lot, Abel.
Is it showing, John?
Yes, it's showing, but not in presenter view yet. We can see the PowerPoint window. Yep, and so if you push slideshow. Okay, and so it's in the presenter view. We can see the notes at the moment. And just while Abel is putting up his presentation, Gibson and everyone in Oro, the team, the communication plan is one thing we hope you complete in the manual very quickly. It's very important, even outside of response mode. I know you said you do meet daily, but not in a formal way, but just having a plan for how often you will get together as a team to look at surveillance data, to look at alerts, things like that. We would really like to see the communication plan. And even tomorrow, if there's some time, we might talk about it as a group and see if we can fill out the plan. Okay, looks like Abel's slides are up.
Copy.
Great, thanks, Gibson. Go ahead, Abel. We can just see the slide now. It looks good. Oh, just so you know, Abel, we can see the notes again. Sorry about that. Let me know if you would like me to share my screen.
Yeah, probably.
Okay. Just open the slide up. Okay, can everyone see? Oh, has it done the same thing to me? Just 1 second. Okay. There we go. So you should just see the slide now. And just let me know when to go forward, Abel. Hi, Abel, can you hear me?
Yes, it's Joe. I can hear you. Just trying to get my screen.
Okay.
Okay, thanks, Joe. So thanks, everyone. I hope you enjoyed the last session. And so in this session, as you can see on the screen, we will be talking about community engagement. So slides will be presented just for the first few minutes, and we will then play a video interviews with some of the PNG responders, and then experiences before we open the floor to hear more from your experiences. Next slide, please. So here are some key messages front for us in community engagement. So communities must be at the heart or center of any public health intervention because we are basically trying to serve them. Community engagement simply means empowering communities towards a better change. And if communities are not at the center of our engagement work, then we can't really serve them better. Actions undertaken by individuals, families, and communities that are being affected are key to controlling the public health problem. That means in a setting where we're trying to help someone, what we do will have less impact than the actions taken by those affected. So for example, you basically have kind of come up with some interventions in response to a outbreak. But if the people of the population you're trying to help do not really understand what you're trying to do, they will not change or they will not listen to you and actually kind of do or take appropriate action. Next slide, please. So here we look at the methods we usually employ for health promotion in the community. Sometimes we use social media messaging. Sometimes we use leaflets, posters, radio spots, and TV. And very, very common means of getting out messages across. But we really do not know if the message is really serving its purpose. But for us as epidemiologists or as members of the rapid response team, community engagement requires much more than the use of these materials. Next slide. So this slide simply outlines some of the key principles to consider when engaging the community, and we will hear more about this from experts when we kind of see the videos. Firstly, ensure you are on the same page with the community you will be serving. So having a very clear purpose or goal. And secondly, I think understanding the community. This involves learning a lot of details about the community, about their culture, about the economic situation, about the political environment, about power structures in history. Because by understanding these, you are able to kind of engage the community correctly, and you're able to achieve what you want to achieve pretty quickly. Thirdly, establish relationships, especially with the leaders and other key people in the community. This helps build trust and makes your work easier. For example, in PNG, I think it was mentioned earlier that the church pastors play a very key role. And then the chief system in some parts of PNG, like for example, in some parts of Central Province, they have a chief system where you can actually work with the chief and actually get the community together as quickly as possible. And finally, use the existing engagement mechanisms. Maybe you already have a great connection or a great program in place. And you can leverage on other programs that are already in place or people you know, and then build around that to actually kind of engage with the community. Next slide. All right, so I am sure you all understand the importance of listening to the community when on a rapid response team response. So listening to those affected is integral part of communication. Through listening, responders can learn about how affected and involved populations and organizations understand and are reacting. And through listening, you can understand their perceptions of the kind of or type of response they provide. And by listening also, you tend to understand the level of trust and confidence in authorities and the potential behavioral, social, cultural, economic, political, and other barriers that might prevent the adoption of the desired measures. So listening is one of the very key things that we as responders kind of observe or use. Next slide. So through listening, we can actually identify a rumor. Not all rumors are bad. Some rumors are useful because they indicate incidents and community perception. So when you pay a little bit of detailed attention to rumors, then you can kind of pick out some things that are important. So what rumors do we care about? I want to ask the team in Oro. You know, sometimes you hear rumors through many sources, but you know, what rumors do you really care about? Can I have some response? You did cover some pieces of or some elements of this in your previous lectures.
Yeah, some church groups not coming forward to, like when we are trying to talk about our, especially with the experience of polio vaccine. They refuse to bring their children forward, stating that it's not normal. So, like the church group were putting it to that part of the paper that you have of 666, and they were not able to bring their children forward for vaccination.
Great. Any other kind of rumor that you're more interested about?
Yes, there was along Kokoda Highway. You guys heard of Kokoda Highway, right?
Uh-huh.
Yes, there was a rumor and there was a march going on that it was a 666 vaccination down 666. That's why there was a misinterpretation when people started giving rumors of 666, and the community were not happy seeing the team on the ground of COVID-19 vaccine team. But that was clarified. We did the awareness to the community and also the children at the school. Children were jumping out from the classroom when they saw the health vehicle coming into the school ground. So otherwise, that was clarified. And one of the things that what we mentioned was community engagement was very priority.
Hello?
We usually roll out the program, engage and talk with the police. So that's one of the things we.
I'll stop the video. I'll stop the video.
Oh, I'm sorry. It was cutting out, so I was trying to save the video. Yeah. Thank you so much. I'm sorry, the audio cut out just for the last minute, just when you were talking about how important community engagement was for the school. We can hear you now. Can you please just repeat the last 30 seconds? It was really important.
Yes, like the rumors on 666, and along the highway where the Kokoda, where in northern province, in Oro, we will have 2 vaccine sites, which is the for health workers, which is the LPHA and Kokoda Hospital. And the rumors was already on the ground where people and the children, especially students, were running away when they see vehicles coming into the school ground. So that was clarified. And one of the things that we've seen as a way forward is the community engagement before the activity is taking place. There must be community engagement done first before the actual rollout of the immunization program. Thank you.
You know what? I'm really excited that you guys are actually using the terms we're teaching you in your discussion. So that's really excellent. You actually provided some excellent responses. Can we go to the next slide? Yes. So you actually gave some very nice responses, and here are some very broad categories of rumors that would be of a concern to the rapid response teams. Misinformation is one of them, which you kind of gave an example. Myths and harmful practices, information that harm reputation and diminish trust in your agency, information that poses a public health risk. So these are things that we as rapid response team members do watch out for and try to ensure that we engage with the community earlier on, like what we mentioned, and then to make sure that we dispel this kind of misconceptions or misinformations. Next slide. So what about social media? Many people have smartphones nowadays, and they are connected up to WhatsApp, Facebook, and Twitter, and so many other social media platforms. So with these applications, people can actually connect with millions of other people in a very, very short time. And so because of this, social media is the quickest way to monitor what individuals or groups are saying. You can tap in how people are thinking and feel, and then kind of when you are designing and your communication plan, as well as your method of engaging with the community, you can basically use social media as well to understand the dynamics before you kind of engage with the community. So I think that brings us to the first part of this, where we covered some concepts, and I believe we're ready for ready to hear from an interview that was done with health responders, and who will actually be sharing the experience and expert opinion about community engagement.
Yes, thanks, Abel. So Gibson, I put the link to the YouTube video in the chat box. Are you able to please click the link and watch the video, because we cannot play it through Zoom?
Okay.
So it's in the chat. And let's hope it works for you. It's a very, very terrific video that James has worked hard to edit and interview Alois, Tommy, and Bernie about their engagement.
No, this is a chat here. It's about the video. Talking about the video, that one is the chat.
Yes, so it's in the chat. There's a link. If you just click the link for YouTube, it takes you to the YouTube website. It's working?
Yeah, it's coming on.
Matters most is building a trust and a relationship. That's what matters most.
You prepare your response plan and indicate where the community engagement will fall in your plan. In your plan, you include operational costs, your target audience, you outline the purpose and what you want to achieve at the end of that response plan, and what form of medium of communication you want to engage with that community, and identify who are the right people that you want to engage, who are the right people that you want to be part of your team going out to that community, their role during the response. Technical officers is relevant, especially during this time, because COVID-19 is too technical, and we want technical people to provide accurate and correct information to clear up these myths and false rumors about the COVID-19 disease itself and the vaccines. Now we are rolling out the vaccines, for instance. You have to send an advance notice to the community you're visiting regarding the response arrangement and your purpose of visiting the community. It's good to always evaluate your response plan at the end of every activity you conducted to identify shortfalls or lessons learned that you want to make improvement for future response. And you know that finally, reporting is a big thing, that you have to compile a report on the activity or your response activities that you do.
Before you consider any community-oriented programs, it is good to know and understand the community leadership structures, the community network, understand what they believe in, their practices, and what they consider as important in the communities before penetrating the communities. So I believe getting to know the community in advance, their beliefs, their practices, and all these things is important before you can actually penetrate the communities.
We normally engage person in authority. For our setting, ward councillors or church leaders, pastors, or in communities where there is a health facility, we use our health network, engage a health worker from that facility, where in a big health facility like health centers or health sub-centers, we have health board committees. They're the people that are represented by the community who works with the OIC and the health workers at the facility to deliver health programs into the community. So we use the existing network, the LLG, arm of the government. So when we meet with the LLG administration, and they have a good network with their ward councillors, their community development officers. So and they have a good network. So any health programs that we want to disseminate to the community, we use these existing networks.
There are leaders in the communities, like church leaders or community leaders or chiefs, right? So first thing we do is you identify who is the leader of each community. All right, so how we work with people on the ground or in the community or in the tribal group is based on three things. So we call that 3 R's. And so before you start working with any community, you need to develop a good relationship. So you need to, talk with the community, identify the leaders, and try and build relationship first. You need to know the people there, then they need to know you first before you start talking about the work you're doing. The second is respect, because in the local communities, like in the mountain, they have cultures that you need to know, or in the community, they have different religion or different cultural norms and a lot of things that you need to know. And so as an outsider, you need to have like a good respect. Respect for the people, respect for the culture, respect for the way they do things. So that one is really important. And then number 3R is reciprocity. That is, before you able to do the work, I think it's good to help the people understand what's the benefit of doing this, how can the community benefit from it, and how can you as someone who's doing the work can benefit. So that's basically how I can summarize how we work with people is based on a good relationship, having respect for each other, and like the equal benefit for you as someone who's doing the work and also the community in the tribe. Yeah.
Your first engagement with a community is very, very important. First engagement. So it is about building trust. So what you actually need to do is get to the communities, sit down and talk with them. I mean, if you don't explain and if you try to get in there, that will obviously chase you out. That will be very, very violent. And when this goes around, the whole communities will begin to realize and they can prevent the health workers from actually getting it. They will never even be prepared to listen to you. So you really need to have to deal with these things very, very cautiously because it is quite sensitive. So you don't create enemies, you don't create confrontation, you don't go and argue your case to be able to push that agenda through. First, you really need to sit down and listen to them. Get the views, let them talk, and then you need to work through with them. Explain all these things and have the support. Otherwise, we are just going to lose support, we are going to lose trust. You need to have a lot of background information, a lot of technical information yourself. What the community, when they're actually talking to you, is to see that they want you to be confident in what you're talking about. You really need to be able to go into a lot of technicalities. It's not just a matter of answering the question on a straight line. And once you're talking to them, you really need to dig into the backgrounds. This is this and that. This is why I think this is this and that. These are the benefits. These are the risks. So if you don't take it, it is going to happen. These are the implications that it's going to have on you. So if we can be able to, go around and be able to explain all these questions, I think you're not going to have a lot of difficulties. So we do not want, in a very sensitive situation, to sell somebody who does not have the technical knowledge about what we are dealing with. Because once you send this kind of people in, they're going to make a total blunder, and then you become losers. So we really need to be very, very careful who we actually sending to the communities in such a very, very sensitive situation.
What we are currently doing now is trying to set up some health committees so that they can have like a contact point that we can work with them. So we need to build some systems in the community so that we can work closely with them. And I think what we've been trying to work with the community is to help them realize that they are important and they are valued and they can do something. And we need to work with community and build some systems in place and build some capacity in those communities as well, because sometimes a lot of the time we just go and do awareness or just go and collect data, things like that. And then after that, we just left the community. And we think that they will, change or they will do something. There is a way of doing things there. They have some cultural rules. They have some different ways of doing things. And I think sometimes we health workers don't understand that. And so they have different churches, different beliefs. And so we need to understand them, understand their context, understand their structures, and then we try and work with them. These systems and these rules are there, and so that's what we do. So we try and work with them, identify the system, identify their cultures, and how well we can, provide the service that is culturally appropriate for different people in the community. They have a different way of thinking. And so I think we as health workers, we need to be, innovative as well and look out for new ideas and trying to help do things differently.
You need to identify key people in a department. Identify the key people, you call them together in one place and you kind of carry out a training of trainers training. You train these guys and these are your focal persons. You can place them all throughout the region so that these are the persons who have to be engaged so that they continue to communicate the same message across to the communities. You don't want somebody to be saying something else, somebody to be saying something else. So you need to have all them together, give them the same level of training, let them point to the communities, and you continue to do a follow-up every now and then to these people. So that is the only way I think we can be able to safely penetrate the communities.
In early 2020, when the news of COVID-19 was hitting China and was spreading across the world, as West, we are sharing the international border with West Papua and Indonesia. There is a high trading with Indonesians and West Papuans because of the family and traditional ties with our people, especially along the West Coast. And this really feared us because it's really, we will be at very high risk because of this. So we said we have to do something before it hits PNG, and we don't know whether it will come to our province or come through mostly because of the international flight. So with having that fear and with having that in mind, we planned for the visit to the health facility, but our aim was to integrate it to engage community along the West Coast so that they are well informed of what is happening and what is going to come regarding COVID-19. So we visited the West Coast villages, we targeted the West Coast villages. We held meeting with short PowerPoint presentations, short videos, all of these materials we use for community education, for advocacy meeting with our health workers. Were downloaded from WHO website. We didn't use any other sources because these are reference materials that we can rely on and back up our messaging or community messaging or our advocacy meetings. So we held meeting with PowerPoint presentation. During that day, meeting with health staff, also meeting with schools, big awareness in schools, the primary school there. In the evening, we visited that. We spent 2 days, 2 nights in the community, showing videos to community village awareness about COVID-19 and the risks. So during that, the first week, few days after the declaration, there were 3 West Papuans that came in. So because the community were already well informed of the situation, they quickly alerted the ward councillors, and then they reported the matter to the district health authority, to our office. And the communities, they went higher, they built a makeshift shelter to quarantine those 3 POIs. So they take it on themselves. So to go ahead with the response, yeah. So this showed how important community engagement was during the initial outbreak. A response to COVID-19 in strengthening community and border surveillance. Yes, so when community are well informed and educated on the risks involved in the benefits, they will actively participate, and that the outcome will always be successful.
Good one.
One of the biggest controversy now is the vaccine rollout. That is what people are very, very suspicious about. So you try to be able to get to some other means, probably to the health workers that don't have much experience engaging with the communities. Through the experiences I have had, my only consideration here is that I think we really need to be really engaged with the community leaders and work through the community structures. You really need to have time to actually sit with them, discuss with them, have a lot of background information about this so that you have one-on-one contact with the leaders, do an advocacy, answer all the questions they may have to raise. Only then should that be able to help you get that message across the communities. If you try to be able to do it alone, I think we will end up in a failure. So the way forward about this is that is the way I think. That is the whole reason why I'm actually working on a proposal now through community engagement. We have to go to the communities and then come back to the health facilities, strengthen the health facilities so that they can actually have that link with the communities. We try to get any other way around, I think we are not going to succeed. So we have to start from the communities and make our way back to the health facilities. That's the only way to go.
Like we've already discussed, there were a lot of rumors and speculations about COVID-19, and these are already like embedded in the village people back at home. Go back, engage the community leaders. Maybe we can hold up a stakeholders meeting, invite the community leaders, provide them with basic information about the vaccines, because they will be the mouthpiece representing us in the community. They can talk to the people maybe on basic information, and then the technical people, the health personnel is to go back to the community and to strengthen maybe the initial information given to the community by their community reps. And I would want the approach that we will take to inform the community, just talking, listen to us talking is not really, not strong enough. We need to show some videos with using our champions, and the champions must be our local nationals, PNG. They want to be like, the Bible, famous St. Thomas, seeing it, believing it, and then they will follow. So we have to show our local national videos on those champions who have received the vaccines. They can share their experience. We will use those to advocate, to do awareness in the community. So then they will see and they can have more confidence and trust in the vaccines that before we roll out the vaccines.
Is that any community-oriented activities, it is always important to involve the communities through their leadership structures and the established networks to reach out to the communities. And that is the only recommendation I can make. And if you really need to get these things across to the communities urgently, it is always important to actually involve the communities. That's the way I think, based on my experience.
All communities they want a healthy community. They want a good life, and they want changes in their community. And so as health workers, it's our work to go down to their level and hold their hands and work with them and teach them what to do and build systems and talk with them, discuss with them, find out their issues, and how do we deal with this? What are the ways that we can help, that will help strengthen and build a good, healthy community.
Great. I'm so glad it worked, Gibson.
Yes, thank you.
That you were able to play it. So Abel, did you want to go ahead? I think we have time, just 10 minutes.
Communicate with your clients,
YouTube's playing.
and business partners. Wouldn't it be nice to have them all in one place?
So yeah, if we just have 5-10 minutes for a bit of a group discussion, because we do have Alois and Tommy. We don't have Bernie, she'll join us tomorrow, but we do have Alois and Tommy and many others on the line to have a great discussion about community engagement. And I think you'll be out of here by 4:15 at the latest, Gibson, you and the team. So much earlier than 5, which is good.
Thanks.
Does that sound good? Sorry, go ahead, Abel.
No, I'm trying to make sure that the Gibson and Tim are still there. Gibson, are you guys still there?
Hello, we are still here.
Okay, great. Thank you for your patience. I think as Joe mentioned, I think we will kind of finish in the next few minutes, but I just wanted to hear from you. Do any of you have any comments about the video? Maybe we can take 1 or 2 comments about the video, and what do you think about the community engagement in general?
Well, as for me, listening to what has been said by our good team leaders who are out there, I think that's the way to go as we see. It's the lack of information that we are having all these problems. So that if only we let our community out there know what it is about what we are trying to implement, then only we can go through, because people have access to so many social media, they are everywhere. And all kind of misinformation seem to get embedded into their minds, and like, because it's not their fault. We have to be on our toes to really get the right information to our people out there. So when we go, they work with us and we implement what we are to take it across to our people. That's the comment I would make.
Oh, excellent. Really appreciate that comment. I think all the speakers, they actually kind of really touched on some of the real challenges and some of the real barriers that we have in the community, and I think we really appreciate them. Anyone else has got any comments on the videos that we've seen so far?
Yes, there's some comments coming.
Maybe come up closer to the mic so I can hear. I mean, we can hear you.
Yeah.
Thank you for the nice video. We have all understood and captured a lot of information. It's really complicated to change people's behavior. With COVID-19, it's really hard to go into the communities because, as you have mentioned in your video presentation, people's behavior is something that you will have to really break through to use some multi-sectoral ways to change. So community engagement, I see it very important in this matter when we're dealing with COVID-19. So as part of as I am in the communication team, this is one way forward where I've just learned a lot from you guys to really go into the community. The important thing that I've learned here is to firstly talk to the gatekeepers or the village leaders in the community setting, where we need to really educate them. And then the first priority thing that the villagers or the people, they need to know is the benefits of why we are going in there. And then if they know the benefit, they are going to accept us. But if we keep them in suspension and if they are still confused, then they will not accept us. So I really appreciate the video. I learned a lot of things. And if I am to be one of the team members in the communication team, I think I am confident now. I know how to start to deal with the community. I will have to talk to the right people, which are the gatekeepers, especially the village leaders and church members and all these people who are looking after the community. Thank you very much.
No, that's excellent feedback, and I appreciate that. So Joe, I think which slide are we on right now? Is it the understanding the community? Yep. So I think we will now have a group discussion about your community engagement activities in Oro. And we have 3 questions that I think in one or the other you have kind of covered that already, but just to kind of structure it and make it more formal. Firstly, we will ask you to map out the community structure that you are likely to encounter in your province. This includes community leaders and the trusted sources of health information, who are the opinion leaders and major influencers who would you first approach to engage before starting an RRT response. Is this different between districts and villages? How will you get the information about that community that you need? And the second question is on is about the potential barriers to engaging while on the RR rapid response team response. And finally, the third question is, what are some successful community engagement methods? John, can we go to the next slide on the structures? Okay, so I believe you've discussed this already, but we want to ask, what are the community structures that we have, and kind of mapping that out. Does somebody want to kind of respond to that question?
What control?
The community structures. I think you mentioned that already. The ward councils. Just before going to the ward councils, what do you think about, like, starting from the families and then to the ward councils? I think that's probably like the basic setup.
Okay, family unit.
Family units, and then the ward councils, and then we got from the ward council we have a councillor that's looking after the ward, and then from the ward councils, what's the next hierarchy of leadership?
Chiefs, president,
the district LLG presidents, right?
Yep.
And then you have the local local kind of local MPs. I think that's more on governance, but I think even within the communities there are some small community structures. I guess like the church
pastors.
Yes, church pastors, and then the congregation.
And some
youth space as well, Gibson.
Sorry.
In some communities, there are youth that make up a big of groups.
Yeah, church groups. I think that's an important point. Youth groups. Think about, when we talk about structures, think about how you engage with different groups in the community. So one, I think for churchgoers, you work through the church leaders, but there's some youths that they don't go to church, but they can work through the youth groups to kind of reach out to them. So that's
sorry, social youth
groups.
And then who are the like the leaders or major influences within that structure? So you can think about people who are actually kind of leading within that community, and who can actually make decisions that will influence a broader group.
Village chiefs, we still have village chieftain system here active.
Okay. So village chiefs, and pastors, do you think they really kind of make decisions that affect the congregation?
Yes.
Okay. And then what about the councillors, village councillors? Okay, that's very good. And whom would you approach first to engage before starting a rapid response in that setting? As a health professional, in order to engage in any of probably one of your districts, maybe there's a cholera outbreak and say a lot of kids are dying, and you just want to go and do some immediate interventions right there. Whom would be, you know, the first person to approach? You think about
health worker on the
in the facility.
health worker.
Yes.
So you see the health workers are also, you know, key players there. And I can think about, you know, the communication, 3 levels of communication, communicating up, communicating across, and this is now communicating down to the recipients of the interventions. Okay. Is this different between districts and villages, especially in your setting in Oro? Are most of the community structures pretty much the same? Is the chip system like kind of, is it a system that exists across all districts?
Yes.
Yes, throughout the province. Yes.
Okay, so it sounds like a lot of the structures that the patterns of structures we've kind of discussed do exist across most of the districts in Oro, so that's good.
Postal place.
And you know, in TNG, one funny thing also is about, you know, politicians and the influence they have. In this picture, what do you really think about, you know, the role of politicians, and do politicians really kind of impact or override the structures that are already in existence within Oro?
It's one of the things that we have seen in the past that could be brought to the authority. That is that the administrative and the politics seems to be doing their own things. Like, for example, we have a team going out for awareness on themselves, like in the LG, the politics, the administration doing it themselves without the health personnel on board. And that's some of the information that is given, which is wrong. But we believe that, you know, like we should have a stakeholders meeting. Everybody's together and come up with a plan together. So we move out together in community engagement with the whole team together in the holistic approach. So I think that's the way forward we can address COVID-19. But if one team goes out without health professionals, without this information like what we have given us, I think there will be equipped. So there's going to be misconception and misinformation to the community. And creating fear. But if we work together like this, to bring everyone into the stakeholders meeting together with the health professionals and especially the incident manager and the team with the stakeholders in the community. Then I think we will get the information to our people, and whatever we want to do, we will achieve it. That's just my point of view.
Oh, excellent. Actually, that's a very good kind of feedback. I guess, you know, politicians, local members, as well as governors, they kind of, even though it's a problem that's happening within the community, but, you know, they get kind of good and bad, you know, feedback as well as reputation. So they kind of interfere a lot of the time. So it's important to know that these structures do exist and figure out how to ensure that the right information is going up and across with your team members, and then kind of communicating that to the recipients of you know, our interventions. So thanks. I think that's pretty much comprehensive discussion. We can jump on to the next piece that we want to talk about. I think that is about community engagement. Oh, sorry, barriers to community engagement, right? So the next question is about the potential barriers to community engagement. Who would like to suggest some barriers or problems? I guess we discussed a lot already, but this can be based on your experience or others you have had. One of them that we've just discussed a while ago is, the political interference with the work that people on the ground want to do. But is there any other that you would want to suggest? Some barriers that could prevent a very effective response.
But we told it before the spread also must go community out. We can grow information about what we want to
Communication barrier.
Communication barrier, And what about like the power relationships in a community where there is differences in understanding between a LLG ward councillor with another LLG ward councillor, or maybe a pastor with another pastor with a different church and teaching and that kind of thing. So that's we need to understand the dynamics that play between the different power relationships. Any other barriers? Communication barrier. We've talked about that already. And then sometimes some communities are actually difficult to reach, and so you may have the right ideas. You may want to do something, but actually you can't really get to those places. Maybe because the district does not have enough money to hire a chopper, or because of certain issues, you just can't get to the remote site. And so those are some barriers that you always need to think about. And then in addition to the communication barrier, maybe the problem is happening at the site where the network coverage is very, very poor. So all these are barriers, and I think when you are planning initially to launch your response, you take into consideration all this.
Maybe another point is leadership.
Yes. You want to elaborate a little bit on that?
Like when there's in some communities, you have like a really good structure, you have leadership, but like if some communities, they don't have like leadership structures there, so you find it hard to communicate like who can you see. But like in different communities, you have a really good structure, so it's easy to work with the right people. Yeah.
Yeah, poor structures, poor community structures. So that's an excellent piece. All right, Joe, we want to go on to the next slide. This one is on the community engagement approach. So finally, what are some successful methods of engaging the community, and what has worked for you before? You want to share some of your experiences here? How do you really kind of get to reach out to the community and actually kind of make meaning out of your conversations?
Are you talking to me or a different person?
Tony, sorry, this I believe is for the team in Oro.
Oh yeah, sure.
By the way, Tony, do you want to give some of your experiences in this?
That's okay. We want to hear from Oro first. Let's give them a chance.
Has anything worked for you in Oro?
Yeah.
Yes.
Yeah, we'd love to hear any of your success stories.
Like we did for the last time that we did the polio, in the actual community engagement, we started with the partners, that we get involved with partners, especially those who are in the community and those who are in authority in the communities. We engage them in meetings and we disseminate information, the correct informations and the method of how to deliver those information to the community. And that was very effective. One of the obstacles that we've seen that, like, for in COVID-19, especially in Oro, was the same the information that was supposed to be delivered was not in uniform. Meaning the politics and the administration is something else to deliver, while we went our own way. So, like, one of the things that we think as a method is to a strong method is to engage the community leaders together, all in all forms, in all authorities, bring them together, get the right information, and get them into the community so that they can speak the right and uniform information to the community.
Okay.
And what methods of delivery did you use? I'm sorry if I missed it. To get the right information out.
Yeah, hello. Most of these methods we use are just only, I say, mass communication, public mass communication. We were doing, but I see it's good. But the thing is that I see in here, I am just learning now is that we need time. Time is another factor. When we, go to communities, we do awareness. We also need at least, adequate time, even though if it means sleeping overnight. So we have enough time. So we observe the communities, we get the views, we have some good understanding of what the community is like. And then that is when we can start, understanding them well, and then we do awareness, I think. So I see time also as important factor in community engagement. Which means I say just going and spending 20 minutes doing mass awareness and then just going off to the next village. Within the 20 minutes, the community, even they do not know who we are. Even though they know us by professional health workers. We need, that's why I'm saying time is another important factor in there. If it means sleeping and staying for a week and knowing the community better, and then I think by then we should be starting to minimize some myths and rumors and misunderstanding, misinformation whatsoever. So this time we need to do this properly. Thank you. Am I off? Oh.
You're still on there listening.
Yes, thank you so much for that input. Very, very helpful and very, very good point.
Another issue here we have, it's about the community engagement methods, but then on the other side of the point, we have this when we engage the community, at this stage, they always expect something when they are engaged, but it's another where we need to be very strong in communicating with them. So like what we implemented, they take ownership. A lot of times we have implemented some community-based activities like during polio. The community take on themselves to put hand washing basin, doing little roadblocks and checking everybody to make sure their hands are washed. But then after the activity, they can, knocking at our doors for some form of payment, and those were some of the experiences that we have gone through. So I guess going through this, we can come up with some kind of strategic plans where we give the responsibility to our community, where they can implement some activities, they own it and they become part of our team to implement what we want to implement. That's the way we we should move forward and doing a necessary commitment and making our work not progressing to where we want it to go. Those some of the things, but I guess as we are going through some discussions, we may come up with some ideas on how we can come out of this kind of issues that we are currently facing.
Now, those are very, very excellent points. I guess, you know, we've extensively also covered some barriers in there as well. But I think it's the context is actually different. You know, PNG has a lot of cultures and you know, different languages, and the context is actually very different. So I think thank you for sharing those perspectives. I think let's look at next slide, Joe. Yeah, so these are some methods that we kind of briefly talked about on how to have community engagement. Storytelling, I think we're pretty much out of that. And then we have a few others that you can see there. One of them is individual interviews, asking specific questions to individuals in the community, and then household or facility observations, visit households to observe sanitation, hygiene practices, and etc. Or visit a particular facility to basically observe. And then you also have seasonal events or event timetables where community members kind of describe changes using a symbol calendar to identify periods of greatest difficulty or vulnerability. We also have community mapping there. This is where community members draw a map of their community showing geographical features and facilities that residents would tend to during a disease outbreak or a other disaster. And then a community walk and observations is walk through the community and observe daily practices and community resources. And then you have discussion groups, which most of you are kind of aware of. Joe, let's have the next slide. So here are some other key strategies to consider when engaging with the community. So that's like involving trusted members of the community, knowing and understanding local customs that might spread the disease, understanding community dynamics, structures, as well as tensions and conflicts, adapt appropriate strategies to help win the trust of the community, engaging the community to explain the risks and how they can be prevented. Distrust of certain actors or authorities can impact community acceptance of, and then also adapting responses to allow people to carry out their traditional practices while decreasing disease. So I think when you're basically kind of engaging with the community, local knowledge is very, very key. And I think that's the reason why having rapid response teams based in each PHA with members comprising of the community themselves is very, very important. Then I think we have the last slide to go, Joe. And then here are some key messages. So in summary of this community engagement session today, we want to kind of learn that the communities must be at the heart of any public health intervention, especially during an emergency. It is critical to know and understand communities in order to effectively work with them in all phases. Multiple strategies and tactics should be used to engage communities. Thinking about your community map and other lessons that you have learned from community engagement, also considering what successful methods can you continue to use. So thinking through all this is very, very important. But there is a place in your rapid response training manual on pages 21 to 22 where you can fill out the community map and community engagement strategies. And I just want to conclude by saying that I think a lot of this, in theory, it sounds structured and very easy, but I think most of the times you just don't realize that you're kind of following this when there is an emergency. And especially in difficult conditions and settings, it's better to use wisdom and kind of think through what is best, and then using appropriate methods to reach out to the community. So thank you very much. I think that brings us to the end of this session, and I'll turn this session back to Joe.
Thanks so much, Abel, for facilitating a terrific session about engagement. I think we could keep talking more and more and brainstorming ideas, but it is 4:30, and I'm conscious that the RRT and Oro want to go home. So yeah, thank you very much, Abel, for presenting and your terrific facilitation. Thanks to Alois and Tommy for joining to provide guidance as well. It was great to hear your input. And yeah, I just want to thank you, Gibson, and the RRT and Oro. You've been terrific today, really engaged. It's really hard when you just have one laptop and computer, one camera to talk to, and it's been fantastic hearing all of your suggestions, your comments, answers to questions throughout the whole day. Really, really enjoyed getting to know you and hearing about your experiences. And thanks, Gibson, especially as the facilitator on the ground, conveying everyone's thoughts. Yeah, we'll all get back together tomorrow, and we'll have some more sessions. We'll have myself, James, Tamri, and Laura again, and we'll also have Bernie and Barry and Dr. Gilbert joining, and many of the other faculty, Dr. Manuel, and yeah, we'll see who else is able to join tomorrow. But really, thank you all very much. I also want to give a very special thank you to Laura. She presented many sessions today and facilitated discussion, and yeah, really enjoyed that too. Yeah, so without further ado, we'll close out. But I think Tamri.
Yeah, we might do the evaluation.
Yeah, Tamri, go ahead. We have one more ask for all of you. It's very, very important.
Yeah, we do ask 5 more minutes of your time if you don't mind. And I just want to say a quick hello to Rigel. It's so nice to see you today, Rigel. We do want to evaluate these sessions because this is the first time that we have delivered RRT online. It is a pilot that we're doing with you, and would love to learn from Oro about how we can do this better and strengthen the online delivery of RRT training in future. So Gibson, do you have the day one evaluation handy?
Thank you. Yes, I've already distributed them and they are filling it up.
Perfect. Thank you so much, everyone. Please be brutally honest. We'd love honest feedback so that we can really help improve this for other provinces. And we thank you all for your patience as we try this for the first time for RRT training.
Are we going to use the same ID and password tomorrow?
Yes, Alois, yes.
Yeah.
Yeah, it's the same link, same password. Yep.
Okay, thanks.
Okay, thank you all from tomorrow. We enjoyed the presentations. Thank you all team for the fantastic work for the day, and we meet up tomorrow again. Thank you all.
Thanks, Gibson. Can I just check? Thank you. Is 8:30 tomorrow fine for the team? That's when we hope to start. If possible, maybe just a bit earlier in case we have technology problems again. Let's say 8:15, just in case.
Okay, we'll try to make it earlier tomorrow. So by 8:30 we should start.
Okay, terrific. Yeah, hopefully we sorted them out today. But yeah, let's try to start 8:30 and we can get through all the content. Thanks again, everybody.
Thank you all. Alois,
Thank you, Gibson. Done a fantastic job.
Thank you. Thank you, Alois.
Thanks. We'll see you tomorrow.
Thanks, everyone.
Bye, everyone. Thank you for joining.
Thank you all.
Thank you, everybody.
Okay. Good afternoon to you all and come out there. Only evaluation sheets, please. Yeah. Fill them up all. Now, line is hey, fill everything. No, valid comments is required. This is the first time or something, so they need all our input for their future training. We are the first session. This Zoom now, so thank you. those who are holding on to it now, tell them to get it down so we can send it over to our team on the other side.